Thank you so much for joining us today. My name is Magali Faciotto, and I am Associate Dean in Stanford Medicine's Office of Faculty Development and Diversity. We are just delighted to be with you here today. Before we begin, I would like to thank Brenda Flores, Lauren Haley, and Kathleen Victor in the Office of Faculty Development and Diversity, and Jazona Alberto from the Office of Continuing Medical Education here at Stanford, all of whom have been really instrumental in planning today's session. This workshop is sponsored by Stanford Medicine's Health Equity Action Leadership, or HEAL network. So I'm going to briefly go over some Zoom logistics. We will start the session with the presentation from Dr. Rania Awad on providing whole person care for Muslim patients. Following the presentation, we hope to have some time for Q&A, and our session will run until 1 p.m. Please do feel free to use the Q&A feature at the bottom of your screen to ask questions, as we will be monitoring the questions that come in. All right, now without further ado, I would like to introduce our presenter today. Dr. Rania Awad is a clinical associate professor of psychiatry at the Stanford University School of Medicine, where she is the director of the Stanford Muslim Mental Health and Islamic Psychology Lab, as well as Stanford University's affiliate chaplain. She also serves as the associate chief of the Division of Public Mental Health and Population Sciences, as well as co-chief of the Diversity and Cultural Mental Health section in the Department of Psychiatry at Stanford. In the community, she serves as the executive director of Maristan.org, a holistic mental health nonprofit serving Muslim communities, and the director of the Rahma Foundation, a nonprofit organization dedicated to educating Muslim women and girls. In addition, she is adjunct faculty of Islamic psychology at Cambridge Muslim College and the Islamic Seminary of America. She is also a senior fellow for the Yaqeen Institute and the Institute of Social Policy and Understanding. Prior to studying medicine, she pursued classical Islamic studies in Damascus, Syria, and holds certifications, ijaza, in Quran, Islamic law, and other branches of the Islamic sciences. And you can follow her at Dr. Rania Awad. Thank you so much for joining us today, Dr. Awad.
Thank you so much, Dr. Faciotto. Really appreciate being here, and welcome everybody. It's wonderful to be here. My greatest appreciation and thanks to Stanford, Medicine for really bringing this on to our Stanford CME office, to our Office of Faculty Development and Diversity. I'm just so glad that we're having these conversations about different groups of people, particularly marginalized populations. And it's really wonderful to be here with all of you. I do hope that this training will be one of use to you, and maybe even a doorway to more trainings in the future related to various populations. Today, our focus is going to be on Muslim populations, and I'm going to go ahead and share my screen. I will let you know ahead of time that my hope and goal is that you will be able to join me in conversation and answering questions related to, the case. There's some cases that we have towards the end here to discuss together, and also I will say right at the outset here is this is a training that we're hoping to pilot in many different locations. And I would really be appreciative if all of you could take a survey right before we begin. You'll find the link to that survey in the chat box if you'd be willing to click on it kind of before we formally begin, as I do some of these introductory slides. And in your kind of knowledge base related to Muslim patients and Muslim populations would be really excellent and super helpful to us as we continue to develop our trainings. I see more folks coming into the room, so welcome. We're so excited that you're all here. And this conversation today is really focusing on improving clinical competencies and providing whole person care for Muslim patients. And I'll define shortly what I mean by whole person care. Hopefully that will be very clear to all of us as we go through this training. I also wanted to say a couple of things kind of right at the outset here. This particular training is developed within my lab. My lab at Stanford University is called Muslim Mental Health and Islamic Psychology Lab. And this particular lab, we focus on all kinds of concerns related to mental health and Muslim populations. We also work on topics just like this one, the combination of faith communities and, in our case, mental health, but more broadly, health in general. So I want to say thank you to our wonderful team that worked on this particular presentation, Dr. Salai Mirzoy, and Dr. Sadia Dhanani, who's actually one of our Stanford residents, which is really wonderful in psychiatry, and Sana Ahmed, who joins me today as well. The John Templeton Foundation has been instrumental in really helping us have some of the funding related to the competencies that we are developing. And it's through a subgrant through Stenson University. And this has been a wonderful opportunity to really further the competencies around religion, faith, spirituality, and members of faith communities. So our thanks to all of those folks as well. Here is the QR code for that free survey that I was referring to. Just a couple of questions, if you'd be so kind to take this. The link is also in the chat box. But this QR code is really useful in order to for us to be able to keep building on this particular training. We've been asked to give a similar training in other universities as well in other spaces. And so your answer is here both before the training begins just now, and at the very end, again, we'll put a link for a post training. And that will be super useful to us. And so my many thanks and appreciation for this. I hope you find this to be useful to you. And with that, we're ready to begin with a couple of just quick kind of disclaimers and announcements. This is a short training, just an hour's worth, and it will not, of course, be sufficient for me to be able to address really Muslims. When we think about Muslim populations, we're talking about nearly 2 billion people on Earth. And so it is really, really difficult to capture that much diversity and that much differences amongst people in a 1-hour lecture. So with all of those caveats, I want to just make sure that it's clear that this particular training doesn't really qualify any of us to become experts in Muslim beliefs, but we're sort of doing our very best to understand where the nuance on Muslim faith populations and on medical and mental health conditions might be very useful to understand patient care. And also that we hope that this really inspires you to go forward and to really help understand more. I'm so, again, happy and honored really that you're here with us today in this learning journey. Here is a little bit of an outline of what I'm going to be covering. We're going to focus first a little bit on what does it mean to have spiritually integrated care. And then we'll focus more on the Muslim faith community in particular and their perspectives on health and mental health. From there, we'll go into the discussions on spiritual experiences and pathology. And we'll end with some very practical nuances on how exactly to work this into your patient care and even your patient intakes and interviews. And we'll have some case discussions together towards the very end. So it'll be a pretty interactive lecture. I hope to see your questions and comments in the chat box as we're discussing here together. All right, with that, we're going to begin. And let's talk a little bit about the American Muslim population, the Muslim diaspora that is here in the US, more particularly and more broadly in the West. So if we look at the world population, we're talking about, like I mentioned, nearly 2 billion people, 1.8 billion if we want to be a little more exact across the world. So we're talking about people from all walks of life, all different ethnicities, races, folks that come from different cultures, really from just about every country of the world. It becomes really important when we look at the American Muslim story that we pay close attention to not just the more recent waves of Muslims that are here in the US that tend to be immigrants from either the Middle East or Southeast Asia or other countries across the world, but we also pay really close attention to the single largest racial group amongst American Muslims are actually African American, who have been here for centuries and many, many generations. And I think that's important. It's a nuance that folks sometimes don't think about. And when we talk about intersectional identities, right, multiple identities, what a person is Muslim by faith, Black by culture or race, and also maybe they happen to be young versus old, maybe they also happen to have a specific profession or trade, and maybe the geography in which they live in all affect who they are and who they become. And those intersecting identities become really important, especially when you're focusing on the marginalized experience of people. And if they have multiple marginalized identities, that becomes even more important to really understand how and why a training like this becomes a very important part of our conversation and discussion. And really to just pay close attention to how it is that we're helping folks that are maybe double, triple, quadruple marginalized. Now, it's also important to say with this vast number of people and this large swath of people that kind of represent the entire world, there will definitely be varying degrees of religiosity. And we'll talk about this in our intake slides and how it is that we work on some of the nuances. But when you think about American Muslims, and you think about how there are folks who have been here for really since the country began, and others who are much newer immigrants or refugees or asylum seekers, there is a pretty big difference in how acculturated a person might be here in the US, how language barriers potentially, also how what generation they're in. Are they the first ones to come here from their country, from their family of origin, or or are they multiple generations in? And I think that's an important part of our discussion too. Even in understanding personal practice and personal religiosity becomes important to the discussion as well. Is it a cultural identity? Is it a spiritual identity? Or is it somebody a religiously observant Muslim? So these are all nuances to ask actually and to try to understand. We'll come to that soon in the how do you ask such questions. So here is a question I'd like to ask all of you, if you wouldn't mind putting your answers into the Zoom chat box and to let me know what you are thinking and knowing about this. What comes to mind for you when you hear the term spiritually integrated care? That would be wonderful for me to sort of understand a little bit about your own understandings of this particular term. What does it mean to you? So let me just give you a moment to think about that as we kind of come through here. Oops, hang on. Decided to stop presenting, but that's okay. I could see some of your responses related to holistic care and other aspects as well. Let's see here. Yep, taking people's space into consideration, reorienting an axiom, nice. Holistic care, being respectful, excellent, excellent. It's happening so quickly. I'm trying to catch up with what you all are writing, which is really wonderful. Yeah, a balance between different things, reducing stigma, excellent, wonderful. Yeah, really appreciate all of these responses, folks. Wonderful. Since I seem to have lost my slide here, I'm just going to represent. Yeah, absolutely. So to come back to the slide here, when we talk about in this training, spiritually integrated care, we're really talking about an approach that addresses the spirituality of a client if they happen to come from a faith community. And that becomes really important because, again, just like we don't want to ignore any one of the identities of a person, faith and their spiritual identities, religious identities, may very well be one of those very important identities to them. And when it's completely sidelined, it becomes really difficult actually for that person to open up and to, in that room, with the kind of vulnerability to say, this is important to me, or the way I think about things that's defined by my faith or spirituality and my faith tradition would think about it differently perhaps than what it is that you're bringing up in the room as the clinician. And so that becomes really important. And most people feel that they can't actually bring some of those things in, or they may feel that there's some sort of microaggressions, really things that are not said very directly, but some judgments that are passed. And that very much affects how well the rapport building between the client, between the patient, and between the clinician will be. Now, I'm going to give an example. I'm in the Department of Psychiatry. I'm trained as a psychiatrist. That's what I do here at Stanford. And I'm going to give some examples in this training that's really broadly on all things health related, but some of my examples will be more specific to mental health because of the fact that I'm a psychiatrist. And some of the literature that I want to point out here, let's take the example of mental health. We find that the literature from, 15 years ago or more has basically said that Muslims tend to underutilize mental health services and are less likely to seek out support of mental health clinicians because they're not feeling that that aspect of their identities is actually coming forward in that mental health care. We repeated the study about 10 years or more after that, and it was the same findings. There is a newer study that's being worked on at this moment that's actually showing some shifting of this. It could be generational. It also could be the fact that as a nation, we have definitely become much more vocal about the discussions of mental health. We have athletes and entertainers and folks who are in media and people who are influencers who are speaking very openly about their mental health. And so at this point, it's starting to become more okay to talk about this. So we are seeing a shift, which is great news for us, especially those of us in the mental health field. But it's really important to understand that as you look at, if we take the example of mental health again, if you find that there's an underutilization of the services, then the question becomes, well, what are the barriers? And could it be that some of the barriers, and this is what the literature shows over and over, that people are not finding they're not finding it comfortable to be in healthcare settings in which they can't bring, and this is a very important term that I'm going to introduce here, they can't bring their whole selves into the care. This is where that definition, this is where that title of whole person care came from. If you feel that you have to leave some aspects or identities of yourself at the door, then are you really treating all of you, right? And this becomes important because often science and religion, historically in a Western context, have been at odds with each other. I would definitely debate that that's different in other civilizations, particularly the Islamic civilization never had an issue between religion and science. They actually work very nicely together and quite intertwined. And so this is not the reality of most Muslims. And so they kind of come to science and medicine expecting that they can bring their full identities to the surface. And when it doesn't happen, it feels really odd and kind of a little bit something is off, like they can't quite put their finger on it, but they're not feeling fully comfortable, which is why we're having, again, this training. And so in an Islamic context, how is it that illness is defined? How is it understood? Because this is probably a good starting point for all of us here in this training. How do we understand, how does this faith group understand illness? So I'm going to share with you a couple of the important understandings here that could give some insight related to your patients. There is a prophetic saying by the Prophet Muhammad, peace be upon him, that says that there is no disease that God has sent down to earth except that he also sent its treatment. And that is a core belief that many Muslims hold. They really do believe that when somebody is ill, an illness strikes, whether it be physical, mental, and so on, that there must be a cure out there. And probably the best example of this is the recent pandemic with COVID-19. There was a whole lot of panic across the globe. In many Muslim circles, we actually published on this and wrote about it. It was very interesting. Yes, of course, there was definitely the panic. And yes, there was the extra toilet paper buying. Sure, that was happening too. But there was definitely a sentiment in that particular community of, well, the Islamic belief is if there is an illness that's on earth, then there will also be a cure or a treatment that comes along. And that, I would say, is very much a core belief and an impetus for a lot of the advancements related to, in my field, I study a lot on mental health. And one of the lines of research in my lab is specifically on historical understandings of mental illness in Islamic societies. And I mean, I could probably spend the whole hour, but I won't, telling you how many advances in the mental health field, psychiatric field, that the early Muslim civilization had come through with well before any Western European nations had done so. And it comes again from this impetus here. So this is good. For those of you who are clinicians, this is great. This is actually good news, because as you work with your Muslim patient or client, you're basically sitting with them and understanding, okay, hopefully from this perspective, I could start asking questions related to, what is your understanding of what's happening here with this illness? Do you understand this to be biological, psychological, environmental, spiritual, supernatural? What are your explanations for illness? And I have to tell you that all of the above apply in kind of that Islamic, from the creed, from the Islamic belief system. All of these are potential explanations. But it's really important for you to ask your patient what they understand from what's happening, because it's very different when someone says, yeah, in my family, we have such and such illness that runs in our family, and that's probably why I have this, some sort of genetic loading, versus somebody that says, I think this is happening to me because, I haven't been the best Muslim lately, and maybe I haven't been praying regularly, or some other, maybe other sort of explanation for their illness. This becomes really important because then you, as the clinician who they're looking to for advice and help, can help with some sort of corrective pieces. Not that you're going to delve into the theology here, that's not your responsibility. And I'm very, very passionate about folks, every person should stay in their own lane. But this is a wonderful place in your lane as a clinician where you're educating on them, their medical or mental health kind of conditions, to be able to, if you see kind of these supernatural or spiritual explanations for illnesses, to be able to say back to that person, to that patient, this might be a great place for you to discuss that with your faith leader, right? Even just acknowledging that and saying that goes a really long way for people from faith communities. And this is not specific to the Muslim faith community. I have met many people who are very much observant, practicing, people from Christian tradition, Jewish tradition, Hindu, Buddhist, and so on traditions that would really appreciate that statement and that sentiment. That there are actually multiple explanations, even if you don't agree with them, that the patient is coming with, and that's important to take into consideration. Now, here are some other kind of concepts that when we did our research on Muslim populations and what they understood related to disease and illness, we found a whole variety of things. Everything from it's a test or trial from God, to it's an expiation of sins, to it's a punishment or a reminder, to it's an opportunity to ask for forgiveness or a growing edge for spiritual growth and purification. And this might be an interesting place to just sort of listen, to reflect, to pause, to understand where that person is coming from, especially if you are giving them all kinds of medical advice and you find them kind of nodding, right? And in the following weeks and follow up, none of these things are actually happening, that there's still some sort of block in what they're understanding or interpreting and what you are trying to bring forward. And if you just had just a few moments to really, kind of ask them the question, what do you understand from this? It might be very eye-opening. And this is where, to go into more detail and to explain more about what I just said there, I'd like to present to you 4 models. And these are models that we actually find broadly, not just with the Muslim community, but I think it applies very wonderfully here. So we'll kind of focus in on the Muslim faith community. But it kind of talks very specifically related to what model are you understanding this illness coming from? So there's the medical model, for example, in which a person is able to say, this particular illness has a biological origin, right? They're able to point to that and it's very clear to them, and they can talk with you and their understanding when you're bringing up, in our case of psychiatry, we might talk about neurotransmitters, or we might talk about hormones, for example. And so they're seeing kind of that biological understanding or genetic loading or something to that effect. Versus when somebody is kind of speaking more from that spiritual or religious explanatory model. And instead, they're understanding what's happening to them to be more due to a weakness of faith, let's say, or maybe the fact that they're not doing something or doing less of something that they should be doing. And so they're kind of guilt tripping themselves. Oh, I must have gotten sick like this because God is mad at me, right? Some sort of explanation that is more spiritual or religious in origin. Versus somebody who might look at this more from a social perspective and say, we're in a global pandemic still, and maybe the person has just been laid off from their job, or maybe they've had a death of a loved one in the family, and there's just a lot of stresses that are happening all around them. So they're understanding what's happening to them more from an environmental, social perspective. Then you have the magical explanatory model. And this model is really much related more to various, well, like it says, magical understanding. So what is that? These would be examples of things like superstition, witchcraft, sorcery. You might hear people say, oh, myself or my loved one got ill because somebody did black magic, or someone hexed us, or the evil eye. Or in psychiatry, often, especially with cases of psychosis, we'll hear things like possession, right, by supernatural forces, demonic forces. And we have a lot to do to sort of figure out and see, again, where is that patient and their family coming from? What are they, what explanations of illness, what explanatory models are they coming with? And where can we bring in Because again, if they've met all the clinical symptoms of particular disorder, how do we bring in this discussion of pathology, of biology into the discussion, but at the same time, not shutting them out completely and sort of negating everything they're saying to the point that they feel they don't have any agency or voice in the matter. This is a really good place where if you feel really stuck, a cultural consultation or a religious consultation, maybe from the chaplains at that hospital, and a cultural consultation, maybe from any one of the offices around us that actually do kind of cultural, like our office, for example, at this Department of Psychiatry. I'm in a division, one of our division chiefs for the diversity clinics. And we offer, within our clinics, we offer a number of cultural consultations. And usually that could be very helpful for people who are saying, I really don't understand what this, evil eye situation is that keeps coming up. And, and the patient keeps saying that this is why they have diabetes. And I can't quite understand why. Can you help, facilitate this? Or even can you help the dialogue around this? And we're happy to do so, for example, offer these cultural consultations. And so anyhow, I think it's really important that we do two very important things, that we check in with our patients and see where they're at and what their understandings are. And on the other hand, we also make sure that we don't overburden our patients by asking them to become our teachers. Can you explain this to me? Right? You do ask that question and you hear what they have to say, but we don't belabor it, because often this also is a place where rapport building gets broken down, where a person feels that they can't actually, that they're not finding benefit in working with that particular provider because the gap is just too big in understanding between them and the provider. So it's a tricky balance. It's certainly one of a delicate balance, and one that requires some, deftness to be able to figure out how to really help the situation. But really just pausing right here on initial evaluation and help and trying to understand where people are coming from does often help go a very long way. There are a couple more things that I wanted to kind of bring here as we're kind of going through the foundations. I would consider these first few slides very much of foundational understandings of working with Muslim populations. So when we look at prevention and treatment within an Islamic context, from that Islamic worldview that many of your patients who are observant Muslims may come from, and again, I am generalizing, but in general, come from, there's a couple of important things here, and one of them is prevention. In many, many ways, you can consider the rules, the ritual laws related in Islam to be preventative in nature. Oh, some reason we went backwards. Let me go back here. Preventative in nature. And by that, I mean, there are certain laws in the Islamic religion that prevent things. So one example of this would be alcohol. I think this is a very common one that's known about observant Muslims, that they don't drink. And by extension, they also don't use any sort of drugs, illicit substances, or even recreational substances, because it's considered to be harmful to the body and harmful to the mind. And the preservation of the body and the preservation of the mind are two very, very core foundational principles of the Islamic religion. So the rules come down to say, basically, alcohol is forbidden or drugs are forbidden. And I think many of us in the health space would probably celebrate that that this is something that's part of many Muslim cultures, but it also might be a point of contention, because on one hand you might have Muslims who are not observant and actually do drink, and it's not something that's being assessed by the clinician because they have assumed, oh, I heard that Muslims don't drink, therefore I'm not going to even ask this question, and that would be neglectful for sure. And on the other hand, it might be problematic as well, because it could be that that person doesn't drink and kind of takes that strong stance against it. But socially, in the environment here in the US, people do drink, and so there might be some tensions related to that. But it's important to understand this concept, that these foundational principles about any harm to body or harm to self would be considered prohibitive in Islam, might actually explain or help explain where Muslims are coming from when we talk about illness and treatment. Reliance on God and faith is a very important foundational principle as well. And this is where the balance is really key to understand. There's this core concept in the Islamic faith that talks about the slang way of saying it essentially is tie your camel. and then depend on God. And what that refers to, it comes actually from a prophetic narration in which it's referring to doing what you need to do, what you have to do, you taking the steps as required and necessary, and then depending on God. That concept is very important. That kind of patience and reliance on God is found in other faith communities as well. It's very much a core principle in the Islamic faith too. But I often remind my patients, the first part of that before you start relying on God is taking your own steps, like your own duty, kind of making sure that you've taken those steps. And that could mean medications. In a medical setting, it can mean medications, it can mean counseling, therapy, right? All kinds of things that people are kind of resistant to, but we remind them, hey, what happened to tie your camel, right? And then depending on God. So that's an important aspect as well. And so is this concept of understanding where there might be an integration between the religious understanding and between the medical or psychiatric therapeutic understanding. And sometimes it works out really nicely that there is a good bit of overlap. I'll give you the example of something like depression. Again, I'm a psychiatrist, so I often give mental health examples. And so, in the Islamic worldview and that kind of faith community and system that people are adhering to as Muslims, one of the main aspects there too, again, preservation of self, preservation of the mind, preservation of the body. And so we remind people, these are core foundational aspects. So if you are telling me that you come from a Muslim background and you're an observant Muslim, then it actually makes it a lot easier for me to be able to say, hey, my understanding in the Islamic faith is that the preservation of the mind and body is actually very important. And when you've reached a point of clinical depression, that probably means that we need to intervene here with either medications, therapy, both, and so on. And that I find actually goes over pretty well. But you sort of have to have a little bit of that nuance understanding. And that's precisely why we're in this training together. Now, the last word on the slide might be a new word for some of you here. It's called ruqya. And what it means is basically the recitation of specific verses of the Holy Quran, the holy book for Muslims. And for many observant Muslims, in addition to whatever it is you as a clinician are providing them, and again, diagnosis, treatment, and so on, they also may be consulting their faith tradition. They may be consulting their faith leaders, and they may also be doing spiritual healing practices. And that shouldn't be something we push away because it may actually be very supportive to them and very helpful to them. Maybe people are finding that coping mechanism from within their faith that's indigenous to their faith is very useful. And so I would temper, how we do that. And I'll give some examples. There's some case examples coming towards the end here that I can't wait for us to actually do them together, because we talk about these very things. Like, do you push away if somebody says, hey, doc, I'm going to I've gotten the diagnosis from you. Thank you. I've started the treatment that you've allowed me to, and I'm seeing my imam who's giving me, these verses of the Quran to read. That might be different for you, but it may be very helpful for that person, and not necessarily encouraging nor negating. It's basically somewhere neutral in the middle, where it's very interesting to you, like you should show interest of like, oh, that's an interesting thing, and explain to me how you're doing that. And if it doesn't negate, my stance on this is if it doesn't negate, let's say the medications that I have giving or the treatment plan that I have in place, but it's actually supportive and additional, that would actually be really great. Neglecting it completely may actually be neglecting something really important to that person. And again, coming from all different faith communities here, we're focusing on the Muslim faith community, is actually quite important to many observant Muslims. All right, now I'm seeing some questions have come into the Q&A box, so I'm just letting you know that I'm going to open that up so that I can see that at the same time. I'm at the same time and see if there's any specific questions that are coming up to some of the slides. So feel free to use that during the course of our conversation here in the training, and hopefully we might have time for some of these questions as well. And if they pertain to the slides that I'm currently working on together, that we're working on together, I'm happy to kind of jump in and answer them right away. All right, so right now we are discussing, as a clinician, when you do an assessment at the beginning. So regardless of what branch of medicine or what type, I know we have an interdisciplinary crowd here, so there's different people from different backgrounds, but most of you, I imagine, have patients or clients that you're working with. And if they're Muslim, the question becomes, how do we start this conversation? I'd like to present to you the cultural formulation that is found in the DSM, where psychiatrists, this is where we go to for our work and the way we diagnose. And I think it's really useful to kind of look at this together. And really, regardless of which field of medicine or any other fields of healing, the healing professions you might be part of, I think these are really important regardless. So you have, for example, the patient's cultural identity. We've spent some time already talking about that. What is a person's race? What is a person's culture? What is a person's background? What is their faith community if they have one? And it's actually quite a simple question to ask. I tell our residents, our psychiatry residents, this particular semester, every year I teach a course called Culture and Religion in Psychiatry. And we go through this very same thing. And we talk about how it's really important to ask about someone's identity or identities, right? Intersectional identities. And to really understand what those are, because then you're seeing a person three-dimensionally and not just from one dimension. You may miss completely religion because many people aren't comfortable asking about that, but it may be very important to the person you're trying to help. Then number two here, the patient's cultural explanation of their symptoms. So we had those slides previously that talked about number two. The four models of explanatory models is what number two refers to here. Number three, cultural components of the psychosocial environment. This is where you start to now understand the broader picture. And I'd like us all to focus in on what I'm going to say here. It's really important, actually. Many, many, many times, the way we are trained in medicine today, or the way we're trained in our health professions today, is very individualistic. We're also living in a very individualistic culture in general here in the US. And what that means is it's usually the provider, the clinician, and their patient, and it's a one-on-one relationship back and forth. However, many Muslims, including people from other cultural backgrounds as well, may come from collectivist cultures. And what that means is it's different than individualistic. It means you're looking at the whole group together. And this could be collectivist as a family or as a broader culture. And so when I hear clinicians say this all the time, I'm talking to my patient, they're nodding, 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 but they never follow up with what I'm telling them to do. They come in week after week and they're not doing what I'd advise them to do. And the clinician is getting very frustrated. And so the question here becomes, well, what kind of background are they coming from? Because if it is collectivist, then you as a clinician have to understand that even though there might be one person in your room, in your office, there might be 10 invisible people behind that person also in that room. What am I referring to? Their family, their spouse, their children. It could be there are multiple different stakeholders that are making decisions together about that person's illness and their care. And if you're not tapped into the invisible stakeholders, then you may be missing completely because you're talking to one person who's not making their decisions by themselves. They're making it collectively. And so it actually becomes really important to see, is that the case? It may or may not be the case, but if it is, then this is where having kind of family meetings, kind of building up in our field of psychiatry, we call it collateral. We're trying to understand who else is a stakeholder and what do they have to say. If a patient is not taking medications, is it them themselves, or is their influence from family? And then bringing them in, because the more buy-in you have, the more likely you're going to get somewhere. So that's what the kind of psychosocial environment is referring to. It also is referring to, when I think about a painting, you might see something in the forefront, that's the core of the painting, but then there's all the background of the painting. That's what the psychosocial environment is about. Who else is in that background? What else is in the background? And that really helps in the care of your patient more holistically. Number four are the elements, the relationship between the individual and the clinician. This is really key too, because for many people, we don't necessarily think about how there is a differential power structure between patient and doctor, or, the person who is holding right onto the strings of that person's care and the patient. And there's a power structure, especially for persons from a marginalized community. That power structure might be even more emphasized. And the person might be very deferential to the doctor, might just sort of nod, 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 right? But isn't actually following through. And it becomes important to understand in our field of psychiatry, we might use the words like transference and countertransference, these internal biases, these implicit biases that sometimes we have, and sometimes shows in the nuance of the way we talk or how we deal with a person, right? Um, and it's really important. And I'll give a shout out to some of the Stanford trainings on implicit bias. I think that's really key and important. And if you haven't gone through that yet, please do, because we all, I'm going to say it again, we all have implicit biases. We really do. Now, number 5, the cultural elements of disease manifestation is important as well. And understanding not just the cultural explanation of what's happening for the illness, but also how the disease manifests. How is that showing up? Because the way, let's take the example of depression that I gave earlier, the way depression might show up in one culture background where it's safe to talk about this, it might be very clear. And the word depression may actually be used. But in a place and culture and background in which it may not be very safe to use, it may show up as what we call somatic symptoms. My stomach hurts, my head hurts, my back hurts, right? But actually it's masked or kind of cueing depression, right? And that becomes important too, the cultural manifestations of an illness. Now I'd like to go into a couple of what I call difficult topics of discussion for you and you as the physician, or you as the care provider and your patient, if they're coming from a Muslim background. So the first of these is substance use. And I mentioned already a little bit about alcohol and drugs are explicitly prohibited for an observant Muslim, in Islam, and for those who are observant Muslim. So this might be a particularly hard topic to talk about if somebody is in fact using, and it may be a reason why they're feeling either ostracized from their community or a lot of shame or guilt. Similar, but not exactly the same as the topic around suicide. And this is something that all care providers, not just psychiatrists, should tap into and kind of really understand when a person is ill, especially a chronic illness or a very, very acute illness. A person may not be in their best state of mind, and really understanding where are they at becomes really important. For a Muslim, it's even more heavy because like some other faith traditions in which suicide or the killing of one's own self is considered to be prohibited or sinful, this is also the case in Islam. And it becomes a taboo or difficult topic to bring up. Different, but not completely unlike the discussion on sexual activity. And here it becomes important too. You may have an understanding related to, just like about observant Muslims not drinking alcohol, you may also know that observant Muslims don't date or have physical relationships prior to marriage. And again, it's a spectrum of practice, and every patient and every person is very different. So we would be neglectful on one hand to say, oh, I think that woman wears hijab. I'm sure she doesn't, I'm sure she's not in a romantic relationship. That would be a big assumption, right? And it's something that has to actually be directly asked and assessed for. Versus on the other hand, a person feeling very judged that they have reached college age, for example, like all the folks on our Stanford undergrad and grad campus who are Muslim, who don't date or have a physical relationship and are looked at very strangely, like, why are you not in a relationship, right? So either extreme is not any good. And really, it's worth just kind of finding where your patient is at. Another place where this comes up and is a little difficult sometimes to discuss is on family planning and the use of contraceptions, all of which are actually permitted Islamically. I know there's other faith traditions in which there are some concerns related to contraception. This is not so much the issue in the Muslim faith tradition, but perhaps more related to specific aspects like the topic of abortion, in which there is actually multiple different responses to that. And it's kind of a bigger issue than we have time for in this 1-hour lecture. But at the end of this discussion, I will give you some resources. And actually, let's put some links, because there's some links in the chat box that you can have related to all of these. We've done work related around Muslims and suicide. There are some wonderful and important links that could be very useful for you as a clinician around Muslims and sexual activity, and also on Muslims and substance abuse. The substance abuse one is actually one of the newest lines of research in our lab. I was just mentioning about abortion, so we'll put in some of the resources for you as well about the range of opinions Islamically related to that might come up related to when, with you and your discussion of your patients. along with end of life concern. There is some nuance here too that is different about Muslims than it may be from people from other traditions. And things like DNR or DNI, or whether a person like do not resuscitate, or do we allow for that or don't, questions related to hospice care and end of life care can be difficult for all people. And there may be some nuances specific to the Muslim faith tradition. So I'm going to leave some links in the chat box for you on these issues as well, since we have a very limited time together. I will also say right here, as I'm going to say probably again towards the end, is that we actually have a much longer training that goes into so much more depth related to all of these. It is a full day training. And so, some folks have decided to, some institutions or universities have taken on wanting to do that. And so hopefully if you're interested, you can join one of those trainings for more in-depth understandings. The takeaway from this set of slides is ask anyways, even if it's tough, even if you're not sure, even if you don't have all the answers. And I hope some of these links that we send you in the chat box here are useful to you, but ask anyways. It's really important that every single person is dealt with the same, regardless of their faith or background. All right. Now, as I come here towards the end, right before we kind of do our case together, I have three aspects that I'd like to show. And as I mentioned before, because I'm a psychiatrist, I think of things in the mental health sphere, and I'm going to use mental health as an example here. Although those of you not from the mental health backgrounds, you'll still find a lot of benefit, I think, from this concept. Here is where we start to ask and delineate when people say, well, how do I know if this is something from the Islamic faith or cultural background, or if it's something that's actually pathological? Where as a clinician, I would call what I'm seeing here pathology versus my patient who's seeing it more spiritual. Where do you draw the line? And that's the question, right? So let's do a couple of things here. The first one here is called devotion versus deprivation. All right. So, oops, I went the wrong way. Excuse me. Devotion versus deprivation. Here are the cases that I was referring to, and I'm hopeful that you can take a look with me here at the cases. We have two cases. You have Inaya and Miriam. So let's do these together. And please use your chat box to let me know. Inaya is an 18-year-old female with a history of anorexia nervosa, restricting type. She has a BMI of 15, and she's here for follow-up in the outpatient clinic. Now, a few months ago, she was admitted to medicine for passing out and found to have hypokalemia, prolonged QT, and SMA syndrome. Now, she really needed some very close monitoring because of all this for refeeding syndrome. And she took her about 3 weeks before she was able to be discharged from medicine. After that, she went to an inpatient unit for eating disorders, and she stayed there for 2 months. She just got back home a week ago. The question here that Inaya poses to you in this hypothetical situation, although very realistic for those of you who might deal with eating disorders, she says, the month of Ramadan, which is the month of fasting for Muslims, starts next week. It doesn't actually, but just in this theoretical story, actually, the next month of Ramadan is in March of 2023, just so you know, towards the end of March into April. But anyhow, let's just imagine that Ramadan is next week. And so she asks you and says, I've just come back home after a week. Can I fast? Is it medically cleared for me to fast the month of Ramadan? And for those of you familiar with this month of fasting, it's no food and no drink from sunup to sundown. And it's not just food and drink. There's also very important parts of the month of Ramadan, and that includes a lot of congregational prayer. It's a very spiritual month. A lot of people break fast together, so they eat together. And there's a lot of communal aspects to this particular month. And when someone isn't fasting, they might feel really left out by and large. So it's very plausible that she'll come to you and ask you, hey, is it okay for me to fast, right? And you as a clinician, just like I am trained in this system, you're trained as well in this system, and you're kind of having all kinds of alarm bells. You should at least have all kinds of alarm bells going off, going, oh no, hold on, right? Are you in a good enough, safe enough place to fast? Now, what's important is that you actually listen to Inaya, okay? Because so many patients, I've met so many Muslims who get very upset by the fact that they've attempted to ask their clinician about their medical condition, when the month of Ramadan comes for fasting, and they're just shut down, like completely shut down, kind of like they won't even be listened to, kind of like, what? No, down, shut down, right? And so even though the answer for someone like Inaya with all these medical comorbidities very well may be no, and there actually is in fact exemption from fasting for those who are medically ill, it turns out that the way you approach this and how you respond and whether you make room to hear her out or not becomes really, really important to that long-term rapport building between you and your patient Inaya. Now let's contrast her to Miriam. Miriam is 33 and she's presenting to you in the outpatient clinic as kind of a yearly checkup. When you look at her charts, you see that she has a history of anorexia nervosa, purging type at the age of 15. And she went to outpatient IOP. She went to an intensive outpatient treatment program in which she did really well, actually. And she hasn't had any purging episodes since age of 18. And she's got no other medical comorbidities or sequelae regarding to the eating disorders from when she was a teenager. Her BMI is 20. Her blood pressure and heart rates are all within normal limits. So the question to you in the chat is, when you compare Anaya to Miriam, how does this change for you? Is there a change? Do you have the same response or are they different responses, right? And as you're putting that into the chat and taking a look here with what you're writing, yeah, excellent. Exactly. I mean, this is really important that you do take a pause and realize that Miriam's case is very different than Inaya's case. Miriam has a historical eating disorder condition that hasn't been triggered by the many, many, many years that she has fasted. This is important too. Muslims fast Ramadan every year. And so my first question would be, okay, so since age 18, now you're 33, in the years that have passed, how has fasting been? Did you fast? And if you did fast, how did it go? Right? And did you have any complications? Were there any other issues? Did anything ever happen? Right? And so just making room for being able to hear Miriam out and not shutting it down immediately as soon as you see eating disorders and someone's asking about fasting would be really important. To back up for a moment, we had the reason we brought up these cases was related to this discussion of, is it devotion or is it deprivation? So fasting, people think of depriving themselves, right, from food and drink, and there's a spiritual, religious component to this, versus devotion. Someone's doing it for religious reasons. And this is where truly with Anaya and Miriam, the answer here is take it case by case. It really is a case by case condition where it depends on their insight, their capacity, their stages of their illness. Is it active, partial, and remission, full remission? Where are they at? Severity, comorbidities, recent hospitalizations, the social support. All of these are important aspects of a person's well-being before being able to answer, can they fast Ramadan or not? This is so, so important and will really go a very long way as an example of how you could be supportive to your Muslim patient in that whole person care. You're considering all the different aspects, their biological and physical medical condition, but also their spiritual, religious, communal, social conditions as well become really important. Now, there are a couple more cases here, and for sake of time, I'm going to go quickly and just let you know that this next case had to do with obsessive compulsive disorder. And it referred to a person who, Layla here, who had OCD. And this comes to the other question of religious observance versus scrupulosity. And here too, we find, where do you draw the line? Where do you draw the line between someone who has a clinical OCD, obsessive compulsive disorder, versus scrupulosity versus, religious observance? So it is normative that Muslims who are observant Muslims will pray 5 times a day. And a prerequisite to their 5 prayers every day is a ritual washing. They wash their face and their hands and their feet before they stand in prayer. And they may wash 3 times, right? Each limb for each of these prayers. That's normative. And having that little bit of knowledge, that nuance, is very helpful, actually. Now, with OCD is when something that is otherwise normative becomes obsessive. And then there's also compulsions related to that. So just in a quick nutshell kind of example here, when scrupulosity starts to manifest itself as cleanliness or in prayer or in matters of creed or like belief systems or character. People start having kind of an existential crisis about their relationship with God or their belief system, and it becomes ruminative and obsessive. Yeah, this is where we start to draw the line between, well, how much of this is normative religious observance and how much of this is actually OCD kind of scrupulosity, right? That subtype of scrupulosity. And I realize not everyone here is a psychiatrist or in mental health. I actually do a lot of work related to OCD, and it's very important to be able to say to a person, oh, we've now went beyond the normative and into the obsessive quality. So this is not someone is, oh, wow, they're so pious and so religious. They're praying so many times a day. No, no, beyond the five, now we're becoming what kind of, it's compulsive, it's extra, it's taking so much more time interfering with their daily practices, right? Interfering with their daily life. And that's when we start to draw the line between what is pathological and what is actually devotional or religious observance. There's one more here that I'd like to cover with you. And there was also a case, but for sake of time, I'll just say this one quickly. And it was a case of a young man that showed up with essentially um, what we would clinically probably call a person with psychotic depression. So kind of a depressive disorder in which there's also these, um, auditory hallucinations that are coming with it as well. Now, when you ask Ahmed, the young man in this case, he believes and he gives you a very supernatural cause to what's happening. He says, I'm possessed. It must be because I have a jinn possession, right? A demonic possession. And here too becomes important, understanding the difference and where you draw the line between mysticism and psychosis. This too is a place of really trying to, you're doing the best you can with the amount of clinical knowledge you have, but you're also trying to make space and room for Ahmed's explanatory models of the illness he's dealing with and trying to understand where that's coming from. As spiritual kind of is it, they consider it to be a possession, and certainly possession is the Muslim community is not the only community that has this concept of possession, not the only faith community, nor the only cultural communities that have this concept, but one of them. And it becomes important to understand, even if you don't clinically agree with this, but to just hear out that person's model, because it may be very helpful to that person to have a faith leader who can actually intervene. Maybe it's the hospital chaplain, or maybe it's that person's faith leader from their home community, right? From that religious community that they're part of. And you building that rapport is, in fact, one extra step, but it's an important extra step, especially if that person's going to get better at your hands. So, really thinking about the inclusion of spiritual leaders, inclusion of faith leaders, having a cultural consultation, having a faith-based consultation might be very useful for populations like this one, the Muslim faith community. Now, in closing here, I just wanted to say a couple more things related to those of you who work directly in hospitals. And I think it's important to remember that for many Muslims, because of the prayers, the fact that they have their 5 daily prayers, and it does come with a ritual cleansing before the prayer, and also because for both men and women, not just women, but both men and women, the emphasis on modesty is also an important thing. So wearing hijab and not uncovering in front of men who are not from your family becomes important and very tricky in a hospital setting, right? Because you might be kind of resting in the hospital bed as a Muslim patient and have male, men kind of come in. They might be students, they might be nursing staff, they might be aides, there might be different people kind of coming through, and it becomes really complicated, right? So discussing that ahead of time and figuring out, can we accommodate this person is very important. Dietary requirements like no alcohol and no pork for those who are observant, and understanding what that means and how does that work into the dietary restrictions. Stanford Hospital does a great job of this and really helping making sure that dietary needs of all patients are taken care of, but worth checking in on. And then fasting, we touched base a little bit about Ramadan and this concept of fasting and how some of this is very much a spiritual, religious inclination for so many people, and it's communal. So if a person feels like they're totally cut off from it, it's not just that they're not able to fast and they have a medical exemption, it's that they may feel a lack of community, and that may be detrimental to their well-being as well. So this is definitely an example of what I mean by whole person care, all of your intersecting identities being cared for by your care provider. As I close here, I just wanted to say that if you wanted some more trainings, and I see some questions in the box about this, here is one that is also free. It's commissioned by the American Psychiatric Association, and it's available. Put the link to the chat here, and you do get some CME credits for this as well. If you're interested in mental health and Muslims, I did this, recorded this along with some other folks, and so you'll get to have a free training that's a little more in depth if you'd like. It's about 2.5 hours worth. And with that, I wanted to thank everybody for their time. I know we went really quickly in certain aspects. There was a lot to cover for sure. And I'm going to leave you with some of our contact information. The lab is very much involved on social media. So we have a good bit of posts that happen every week, just about multiple times in a week. So please do follow us on social media if you're on there. And so we'll put some of those links in the chat box as well. And lastly, just one more plug for our QR code for our post survey training. If you found this useful or you have any feedback for us, here is the QR code and the link. So please do join us in kind of putting in that survey so that we're able to know how we did and where we can improve. My many, many thanks to you all, and I turn it back to Dr. Fasiato.
Thank you so much to you, Dr. Awad. That was just incredible. And we also want to thank you, our attendees, for your engagement today. The session today is being recorded and will be made available in a few weeks on the Stanford CME page. You also have the opportunity to earn CME credit today. The instructions are on the screen where you can sign in or create a new account on Stanford CME site, and then you can claim your credit, and we have the code there for you to claim your credit. That was just so enriching. Thank you so much. We look forward to providing additional educational opportunities throughout the year. We in Stanford Medicine's Office of Faculty Development and Diversity, Office of Continuing Medical Education, and the Stanford Medicine HEAL Network are passionate about sharing knowledge, resources, and support with the goal of working toward a diverse, equitable, and inclusive community. In community, people are a powerful force for transformative change, and we invite you to both build and take part in our transformative community for change. Thank you all.